Okay. So, low back control directional subgroup in impairment of control. So, let's go. So we've got flexion pattern, which we've gone through. We've got that active extender group where they're like hyper braced. We've got patients who are the passive extenders, which we did previously. Ipsilateral. This is where they're not really responding to when you get them to stick their hips out. You get them to relax. It doesn't really change anything. You put the pressure through your shoulders and you get them to shift forward. Doesn't really do anything. So they're called an ipsilateral pattern. So they have pain normally on one side. So that's the first thing. It'll be generally one-sided, and it'll typically be up higher than the back. So it might extend down into the lumbar, but it's centered around that QL region, right? Now it's pretty easy. Basically, it's either a hyperactive QL or like an underactive slash in inverted commas weak QL. Okay. So it'll look like that. Like they'll come in with pain there. Not typically sciatic, not SRJ. It's in that zone there. Right. What things bother it? It's your sitting to standing, 2 legs, 1 leg, prolonged standing, squatting, bending, lunging, lifting.
No, it's not.
They may have a Trendelenburg when you watch them walk, either compensated or positive on that side. Okay. What would I do? So we'll stop for a sec. Does any of you have pain in that location? Do you a bit, Dave?
If you can't help
You have to come up and
yeah, that's where I get mine. That's where I'm saying.
Is that where you get yours?
Yeah.
Okay, perfect. Which side?
Left side.
Okay, sweet. All right, that's great. Should we have a look?
This is only last week I had an acute flare as well.
Really?
Yeah.
Must be meant to be, mate. Come up. Now, point and show us where you get it.
I get it there. Right.
Right. Great. Okay. So, turn around and face. Can you put? You don't have to take your shirt off if you don't want to, or you can take your shirt off. It's probably easier. But if you don't want to, can you just like pull it up and expose that area of your back? Okay. In there. Yeah. Great. Shimmy off to the go step forward like a meter. Move over to the right a little bit. Okay, stand on your right leg. And then can you just shift over to your left leg? When you do that, does it bring on any symptoms at all?
I can feel the difference, eh?
What do you feel?
So if I'm standing there, I feel like it's quite neutral. But as soon as we do that, halfway. Is it on that left side?
Yep. Does it hurt?
No, not the moment, but I can definitely feel it. But you can feel it's going to bring something on, or could bring something on.
Okay, go to your right side now. And then I want you to hitch up your left hip, like kind of pick it up. Yeah. So when you do that, do you feel any worsening on your left?
Yeah. Well, I can feel the discomfort there.
Yeah. Now drop it. Does that ease it?
Yeah.
Okay. Yeah, cool. Sweet. Go onto your left side. Now hitch up your right. What do you feel?
Yeah.
And then drop it down. What does that feel when you do that?
Just straight up and down.
Does it take the pressure off your left back when you drop your hip?
Yeah, it does a bit. It feels a bit more relaxed.
Yeah. Okay, cool. So this is pretty classic. So it's almost like the QL goes into tonicity or more spasm, right? Keep facing that way, mate. Stand on your right leg, and I want you to just do like 10 squats on that side. Just little baby ones like that's cool. All right, when you're ready, do the left. Yes, you're doing some weird stuff on there, but how does it feel?
Oh, it doesn't feel particularly coordinated.
Does it hurt it?
No, it just feels a lot more edgy. Yeah.
Okay, stay on the left, and now hitch your right hip up, and do the same squat.
I feel it's pretty
Worsening pain or not so much?
easier.
Okay, now do the left and drop it. Switch to the left side. Go back to your left and drop your right hip. Yeah. How is that?
Yeah, it feels better, right?
So arguably, do you think we use this phrase when we started, right? We use it here in WA. We say adaptive or maladaptive, helpful or unhelpful. Do you think? I'll ask the team. Do you think Dave's resting? Yeah, you can check your shoulder. Do you think Dave's resting single leg stance posture is helpful or unhelpful? Based on some of the stuff we just did.
Probably helpful when you're in acute player, but not at this stage.
Yeah, exactly. You've got it. So like basically, and that's typically what the patients will have. Acute correlates to helpful. Like they'll have it, or what we call an adaptive. Like it'll be like the body's trying to protect it. But like if it's a week on, it's typically unhelpful. So he had like a compensated Trendelenburg, in my opinion, on that side. So his hip was all bunched up. When we got it to drop, it actually took the pressure off his back.
When it goes, when I get an attack, I get a big shift.
Do you? Like a lateral shift, do you? Yeah. So like that, it's always hard because you can't. The idea of this system is it allows you, depending on the individual presentation, to be flexible and and provide specific exercises depending on how they pull up. So last week, it might have been that we'd heighten that protection. But if he came in like he is now, I'd probably be giving him strategies to relax that leg off, and I'll go through some of those. Okay. There's a couple more assessments that you could do though. So I would look at like the squat like that. I'd also look at how he stands up. So if we get like maybe a box perhaps.
Kierian, can I just ask, when he's standing on the left leg, he raises his right hip.
Yep.
What action is the left QL having there, and the opposite when he drops it down? I just need a revision.
Now, this is always like a bit confusing for me, and I'm the one teaching it, right? We would normally say that if he's on that left side, and he's picking up the right, that's activating the left QL. Like it's like
Yeah.
shortening.
Yeah.
Whereas when you drop it, so if you drop that right, it's lengthening. So like, the point is, I don't really know how the patients are going to present. So that's why I kind of like just do a series of tests.
Yeah.
And then you basically give them whatever's comfortable.
Yeah, whatever changes.
Whatever positively. It's kind of like the guys in Queensland love the TDTs.
Yeah.
And I think they're cool, like, because it just kind of, it's flexible. You can like use it. But it's not a manual technique. It's like a hands-off technique. Right?
Yeah.
All right. Now, we'll check how he goes with this. So pick up your left leg there, Dave. Put your right foot down, and so pick your left knee up in the air. Stand up from there. Tell us what you feel in your back if you feel anything. Whoa, geez. All right. Do some reps if you can. Okay. Left.
Right here, man.
Bit wobbly. Does it hurt? Nothing? Okay. Okay. Now, shift. If you guys watch him from the back, do your right side. Tell me, so just do 10. And then we'll check for the compensated Trendelenburg when we do the left side.
Okay.
What's happening when he does that one? Any difference?
Yeah, I reckon.
He's got a bit more of a lean in his left.
So does he lean off to the left? Yeah, okay. So now, do the left one again. This time, before you get up, think about like kind of dropping your right hip and if anything, like leaning off to the right a little as you come up. Does it change where you feel the effort?
Yeah. I don't feel like standing back anymore.
Yeah. So sometimes the patients, they're like, it's sort of like an active extender, like they're kind of bracing it up, but they're bracing it up off to the left or off to their symptomatic side. So you have to get them to like drop off like that. So I would look at, first thing I'd do would be looking at single leg standing. Then I'd look at single leg squatting. Then I'd look at sit to stand like this, right? Have you got a step?
Yeah. Sit.
All right, push the step forward. Come face this way, Dave. Stand on your right leg. Bring your left leg off the edge of to the left side, so you're kind of just standing in midair. Okay. Drop your left foot down to the ground and pick it back up. Keep repeating that. Let's do 10.
Good job, girls.
What do you get? What are you feeling?
Mario, get your beans, put it in, Faz.
Okay. Flip over to the other side.
Thanks, Meme.
This one's definitely looks harder.
Yeah.
Where do you feel it?
Good on the board, yeah.
On the other side.
I don't feel much here. Find it hard to do from here.
All right. When you go back to the right, this time, like kind of fully relax the leg off. So yeah, and then drop it down and come back up.
All right, man. So well.
That's the way. You got it.
Thank you, Paz.
You feel it more there, the glute?
See, I can start, when I pull up, when I get to there, that's
Yeah.
the
That's the pain?
yeah, so, yeah, it's fine.
Thank you, Paz.
Yeah.
Yeah.
We're just saying goodbye and thank you for having us.
Yep.
Well, let's say-
Okay, now go back to the left. So when you stand, drop first, like just let it drop, and then drop a little bit further so it's kind of like lengthening out. And then pick up. What is that like?
Yeah, pull it there, do that.
You feel that, do you?
Pull it up, yeah.
Yeah, good.
And then
All right, let's get what's the heaviest weight we got?
okay.
Let's give him a 10. Let's give him a 10.
Whatever you want, Kierian, it's what there is.
40. Nah, let's give him a 10 kilo. Show me right side. So start dropped. Yeah, and then like low. That's it. Keep repeating this. Just tell me what happens.
Yeah, it's not so, it's starting off like that.
Okay. Go switch to the other side. And stop if it's too sore, but it should actually feel kind of nice.
I feel fine on the left, eh?
Is your glute working more now?
It just feels hard work.
On the back?
Yeah,
In the glute, yeah.
it's just the back, yeah.
That's not sore.
But not sore enough.
All right, can everyone give that a go? We'll go straight to the weight for the people who don't have broken backs.
Hold and back. Yeah.
So that's we'll do some other stuff, but yeah, these would be the like functional tests for motor control that I'd do. But don't use that stick, mate. That's cheating. Try not to use the stick.
Put your thighs in that.
Order them now.
So it's like a lateral flexion test of what we used to call it.
Yeah, it's like I'll show you some other ones in non-weight bearing, but these are the sort of things that I would do if the patient's got the pain exactly where you're pointing.
Yeah.
I'm basically wanting to like see, is it hyperactive or is it like too loose sort of thing? It's not active enough. And yours was pretty predictable, which helps. Yeah, and it fits your history.
Side I'm working.
Beg your pardon?
I find it hard to tell which side I'm working. Like, I feel like I'm tracking both.
It's kind of weird. Like you'd think that when you're on this left side, like so if you're standing on your left leg, like I would assume you're working your left QL eccentrically when you drop down. That's what I would think. But for some patients, the way they're so in this example, if you're on your left leg standing on the step, you're obviously working the right M1, so the opposite side of the cortex, right? And I think for some patients, the pattern at which it fires is kind of random. Like it just fires differently, especially if they've had chronic.
You guys can watch
So the others, can you just give it a go? Just tell us what you feel. I would almost say sometimes as well, 10 kilos honestly might be a bit light to invoke sensation in the back. The QL is very strong muscle.
It is the way to provoke symptoms, not just.
I kind of like, I'm looking to see if because sometimes it's symptomatic. Sometimes, like, the more you activate it, it becomes like a therapeutic exercise. So it actually brings it on and then it kind of eases it. And then try to think about, like, dropping your hip, like letting it go, and then controlling down further. Yeah, that's better. All right, does Soph want to give it a go? But I reckon try. Have you got anything heavier, or is 10? Do you reckon 10?
Yeah, we're going to 30. You can start yourself.
I reckon try like a try something heavy if you. I don't think it's going to be a compo scenario.
Maybe just
Yeah, that's the way. But you try to keep your legs straight, so you don't actually squat. You just kind of drop your hip off to the side. Okay, go back to the other side.
That more like here.
Yeah, when I up the weight,
Yeah.
I felt it.
Before I put it like just on the standing glute.
But really?
plug in, check the focus on the plug.
Did you guys learn this? Did you guys learn this undergrad? We didn't. We didn't learn this undergrad. We only learned it in postgrad. So it's kind of like you're like lengthening out that left leg. So in this instance, you'd be working right QR, would be what we'd say. Yeah.
Yeah.
Do you feel it?
Just trying to balance the moment.
In the wall, push the cord in the plug. Sometimes there's a bit of a loose part that's
Got harder on that side.
Yeah. Yeah. Okay. All right. So this would be the stuff if they're like kind of not too irritable, right? The next position I would do would be, have you got a bed? Can we get us a bed? Okay. We'll get Dave. Grab a pillow if you can. Yeah, this maybe bring the camera around a bit too. Bring the camera around a bit, or bring the bed closer this way. Yeah. Okay. Dave, let's lie with your right side up first. Chuck a pillow under his head there.
Yeah.
Little towel. Now, bend your bottom leg. Straighten out your top one. So it's kind of a bit more forward, like a bit more forward. But drop it. No, like off the end of the bed. Drop it down there. Not behind, sorry. Just like kind of mid shin. Yeah, about there. Great. Now, what I want you to do is extend out through that right leg. Like lengthen it out. Yeah, you got it. And then bring it back up. Do some reps. Okay, Tim, can you go, as he goes down, I want you to put your hands just past his his greater trochanter and stop him doing it.
Like provide resistance.
Provide resistance as he pushes away, and then as he comes back up, grab his iliac crest and pull the opposite way. Is that? Do you feel that? Do you feel like you're resisting him?
Easier to block on the other crest, but yeah.
Yeah. Okay, now flip onto your other side, Dave. So flip onto your right. Onto your right. Maybe put your head up this way and face me. Yeah. Yeah.
See the dexterity there.
Hey. Now, yeah. Now just without Tim resisting, can you just lengthen it out and tell me what you feel in your left side?
That's sort of,
Is that sore? Do you feel it in that zone?
yeah, and a bit lower, right? Yeah, that's
Yeah. So he's like a stereotypical this. Me and him haven't met up and like decided that. Yeah, this is just like his back. But so what do you think we're assessing here when we do this?
ability to control and lengthen.
Yep. Yeah, and like whether it's painful or not, whether it's now, can I get you to, Tim, do the same as what you did on the other side? Does that change it at all when he does that, Dave?
Well, it was painful, but it's a lot harder to do than it was on the other side.
Is it more hard? Is it harder on this side?
I don't know.
Yeah, I feel like a lot harder to do, but it's not.
Yeah. Yeah, crazy, eh? So get down and do the same thing, Tim. So you give Dave a practice of resisting it. So these are assessments I'll do if I think it's this subclassification.
That's better.
So as he lengthens out, we resist from his trochanter. As he pulls it back up, we pull from his iliac crest down. Yeah.
When you do that, you're looking for changing symptoms, yeah.
You are. Yeah, you are. And then like obviously if it's like sometimes with these patients it'll be pain relieving. But it's just they're all clues to tell us that the QL's implicated. Okay, there's another one we can do. So if you how are the girls going there? Are they picking up what I'm throwing down here?
I did it on the ground. Okay.
Do you sort of get what I'm saying with this? Okay, I'll show. So like basically, I always try to go functional first, right? And then I'll regress to side lying if they're like quite sore. Like, but it's just interesting that Dave gets it with these tests. It's kind of what we're hoping for. Now have a line to your back, Dave. All right. Straighten out your right leg. I want you to push it out, like you're lengthening out that whole leg. And then hitch it back up that side. Keep going. Did you get anything on the left or not?
Bottom I do.
You do?
Feels easier at the bottom of the movement.
Okay. Now, same deal, Tim. I want you to get in. When he's lengthening it, I want you to like put your hand on his foot. As he's pulling it back up, I want you to resist at his ankle.
Well, hard work, man. Well,
Okay, now let's check his left. So just do it by yourself first, Dave. What does it feel like
doesn't look like what else? Our hitch. Like
when
it's all,
you pick it back up? Is it sore?
yeah, but it's up there. It's sore. Push it away. It's almost like it relieves it.
When you lengthen it?
Yeah.
Yeah, so like if Dave came in today, I would be giving him leg lengthening. Probably, I love the one on sideline where they're kind of like extending it out like that. But if that was too sore, I'd give him this one. And I'd get him to practice lengthening and then back to neutral. Lengthening and back to neutral.
Even the QL is working really hard. That's quite nice.
It's pretty good. Yeah. It's like, I didn't learn about this until like 10 years postgraduate. We just, yeah, I'd never thought of trying this stuff. Yeah. Now, can you resist him there, Tim? So like just, it should actually feel a bit better when you're resisting it.
It feels nice.
Does it feel nice? Like it's kind of like working it? Yeah. Okay. There's another one you can do, which is like kind of in between the standing and these side lying and supine. Flip onto your left side again. With your face facing this way though, so head up the other end. Legs out, like both legs out. And then prop up on your elbow. And put your right hand on your right hip. You can't lift that bed up, can you, really? That's fine. Bend your knees. Pick the knees up towards me. Lift your right shoulder up, like you're side flexing it. Side flexing your trunk to the right. Yeah. Yeah, that's it. And go back down. Keep going. Put your hands on his rib cage now, Tim.
Guys, can you guys just watch the show, please, and drive me not to actually bonkers?
Wow.
You can just push the whole time.
There we go.
Okay, flip to your other side.
Holy.
Girls, watch.
Don't resist him first. Did you get anything or not?
No, not really.
No.
On the right side, it's just more of a
This one's a bit more of a stretch, or?
I'm not ordering it. You are driving us bonkers. Find a movie, go to your room and start watching now. Now!
When you resist?
We have stuff to do, Pascal. Because
Feels good?
Even though I wasn't getting anything left side, that left side started to feel sort of more comfortable.
Yeah. Okay.
Close your door, it's too noisy, I can't think.
Okay. So, last thing. So, like, there'd be some of the things I'd be checking, right? And then obviously the exercises kind of follow based on what provides the most relief and what's most comfortable. Flip onto your left side first. Left side. Pop the pillow under your hips though.
All right.
And then grab some, have you guys got like sorbeline cream?
I'll strip it.
Yeah. Pop your right arm over your head. Bend your left leg. Straighten your top leg. But don't have it over the back like that. I'd have it just over the end of the bed. The right leg. Okay. This would be if I'm palpating QL, this would be the position I'd get him in. Okay. Pull that shirt up. Can you bring the camera up over him?
I have to unplug it. Is that okay?
As long as it's got battery, I guess. Yeah.
Oh, we're just like putting it on the knee. I can't see what. Oh, yeah. I said over, like that.
Yeah. Yeah. Perfect. So, if I pull up my anatomy, this is your. Where is it? One sec. Sorry. Here.
Oh, good. I'm good now.
Point to where you've. No, it's the opposite side. One sec. Sorry. This is just a bit slow. Where's it gone? Oh, here. Okay, so the origin is at that iliac crest, right? Into the iliolumbar ligament. So it's down. So if we'll palpate his right first. So it's down close to near where the PSIS is. So if you find like L5 and just go off to the right, and along that line of the iliac crest, it's about 5 centimeters there. That's where it originates from. Okay.
Yep.
So it is a bit. The thing that the thing I always remember with QL palpation and treatment is it's quite a lot wider. Like to get to it, you have to come out a bit to the side. Yeah. Now, with your other hand, or you can use that hand, go down to the 12th rib. So you sort of like, I'd normally start lateral, and I'd dig in and I'd come down. So that's where your insertion is. And it obviously like inserts into those transverse processes between those. So like L1 through 4.
Yep.
But so where you're pushing now, where your middle finger is on the right, basically from there up to the floating rib, 12. So push in hard there, like deep. And then work your way up to the rib 12. Okay.
Yeah.
Now, flip him over.
Yeah.
Flip him over like a steak. And then we'll check his left, and I'll bet you a chocolate bar it'll be tight and sore. So just come up over there, Sophie, if you can. Remember, it's quite lateral. Like we're kind of like, it's almost perpendicular to the bed. Yeah, there. Or even a bit more, like a bit more around. Yeah, there. Dig in hard though, man. Like deep. Is that where you've had it, Dave, or?
A little bit medial side.
Yeah, a little bit medial, yeah.
A little bit medial. So it's typically somewhere between the spinous process and like 5 centimeters around.
Yep. Yeah.
So, have you got Sorbeline or anything? So this is the position I set. If I'm going to do manual for soft tissue, this is the position I set him up in. And I'll have that, but see where the pillow is? I'd put the pillow under his hips. So it's basically putting the QL on stretch.
Again.
Is that where you've had it, Dave?
Yeah, it's a bit medial to that.
Doesn't feel particularly pleasant at all.
Is that pretty brutal?
No, it's there.
Is he paying you well, Tim?
I think last week I wouldn't like this at all. Eh?
No. Yeah. This could be a good time to negotiate wages.
I don't think I'm that mean.
No. So this would be like, do you guys needle in there or not?
Yeah, sometimes.
Look, you can needle in there. It's like the only issue is if you're going up high, like if you're going up towards the insertion, there is pneumothorax risk, and you've got actually kidney risk. So if you look, can you see that picture there? So
Yeah.
if you're putting it in there, like that's QL.
Yeah.
And so, like, you're getting pretty close to the kidney.
Yeah.
So I would be cautious doing the needling in there.
Yeah, I tend to do more like what are they called? Huato TRG points, the HTJ,
Yeah,
like L3 and down, because that's clear of the lung fields.
pretty much. Yeah. So now, have a lie back onto your back, Dave, if you can. And then just lengthen out that left leg. Tell us what it feels like.
Yeah, bit better. Eh?
Bit better?
Yeah.
That's perfect.
Well, eh?
All right. Can the others, if you haven't already, can the others just have a bit of a feel and go of QL on each other? So this would be my protocol's the wrong word, but this would be the sequence of tests that I would do for someone who I think's got ipsilateral, exactly like Dave's describing.
I don't think I've done that. Yeah,
You can also get the patient like Tim is. You can get them actively to like stretch out. So you reach your top hand over, Tim, like more, like you're kind of reaching over your body like this.
oh, like behind it. Coming right up.
Like that, yeah.
Sorry.
So that would be the exercise. This would typically be if I was going to stretch them, this would be the stretch I'd give them for home for QL.
The other one I was showing with this is like you do your trigger, your massage.
Yeah.
But your one hand iliac crest, one hand rib cage.
Yes.
You can't distract.
Yeah.
Right.
Yeah.
It's sort of like almost like a muscle energy technique. I guess.
You can do that, and you can kind of fuse a bit of the other stuff we were saying. So like you can get him. So if you're doing that, pick your left hip up towards your left shoulder there, Tim. Yeah, and you resist him. So push it away, and then you push up, and you'd hold it for a bit, and then relax.
Mobilization with movement, but it's soft tissue, not joint. Isn't it?
It is. So it's actually technically it's a mulligan, muscle mulligan. Yeah. Yeah. So this sort of stuff would be. So I'm thinking like, do I strengthen it? Do I lengthen it? Do I treat it? These would be all the techniques I'd use for someone who's got that ipsilateral, and they're not responding to like relaxing the back or like sticking it's not sagittal, it's a transverse plane impairment. Yeah.
So they're home stuff.
Yes.
You're almost just trying to get them to lengthen that lateral side.
Yeah. So you can lengthen it through the thorax, or you can lengthen it through their pelvis.
I've done things like that sort of ITB, stretch your arms above your head. And
Well, that's what I was going to ask you guys. Do you guys have any other ideas what would be some other passive or active exercises you could give for QL, or that you'd normally give for QL?
to calm it down. Just sort of like if you're like detoning and setting the situation down, or like stretching it.
Yeah.
used to do things like lying over a Swiss ball, but I tend to use it to carex a lot more, the door jam.
Yes.
So stuff.
Yeah.
Do you want to show us?
Yeah, put your hand in. So I say that. My go-to would be like that. Up, and then back and right out. And if they don't like extension too much, then I'm quite happy. I'll put them a little bit of flexion. Can get that going?
Love it.
Do that, or the other one, door jab. Put it right in there. And just come out
Love it.
and stuff.
Does anyone else have any other ideas or stuff that you'd normally do?
Yeah, similar, but off like a kitchen bench. So they're in more flexion. Yeah, or
Yep.
like a sub pose of the walk.
That kind of thing. Yeah. Anything else?
Deep breath, yeah.
The other one I'd sometimes give, if you everyone get into the hip flexor stretch position, that kneeling hip flexor stretch. Tuck your bum under, lunge forward, and then put your arm over your head, and then lean forward a bit, and breathe. So I'll give them that. That's a pretty good one. The other one I'd give everyone just sit down on the edge of the plinth or on a bench.
Absolute breakage.
And then, so like if they're like really sore, you could just get them sit with your feet flat. You could lean literally just slump forward, and then you can just try leaning off to one side with your arms down, hands down. Yeah, I'll sometimes give them that if they're really stuffed. I'll give them that kind of thing. This would be most of my treatments for these presentations. Yeah.
How non-irritable do they have to be for you to want to challenge the sore movement?
I think that's a very good question. Like, it's actually kind of serendipitous that Dave's had that kind of tweak last week, now easing. We would normally say that they're adaptive, helpful for the first 24 to 72 hours. It's sort of like when they get a list. Like, the lists are actually quite helpful short term. If you try to because the thing, when I first trained, everything was about correcting the list. But I think if it's helping initially, you wouldn't want to try to provoke it too much. I would just let the body do its thing. Maybe support it, strap it up in that position, if anything. And you can't, so all those stretches, you do the exact opposite. So you kind of shortening the QL, so to speak. Whereas as it gets better, you generally find that it likes to be lengthened out. It likes to be kind of mobilized into more eccentric. Does that make sense? Yeah. So that, in my experience, but based on this classification system, these would be the things I'd do.
So the initial acute list is not really maladaptive, it's actually adaptive.
It's adaptive. Yes.
So when I correct that list and making it worse possibly wasn't the bright side.
So I came to that conclusion about 10 years ago, because I was on these courses and they're like, you need to correct the list. I'm like, how come? But if the body's doing that, why wouldn't we just but what will happen? And because I know I've had an acute back flare last year, I think it's probably 24 to 72 hours. It'll be adaptive. So I maintain that list, but then I try to coax it back to normal after the acute inflammatory nociceptive.
Is that thinking maybe sort of come from Mackenzie's idea? of the shift. Address the shift, then get the extension.
I think like a lot of the earlier Mackenzie stuff was completeless correction from the get-go. But this is like, it's not that we're ignoring Mackenzie. It's just when you try to return it to normal. I probably think you got to give it a few days, like to just let the natural inflammatory process get underway. That's what I've been doing with patients for probably the past 10 years, yeah. But the first 10 years of my career, I would smash them. I'd try to just get them more and more free, but I just found if I did it too quickly, too soon, it was just more irritable.
When they're in those first 3 days,
Yeah.
I think there's much we can do to help their pain. I feel like they kind of like,
Yeah, well, there's an old joke. It's like, 3 days of physio or 3 days of bed rest. It's like kind of like pretty much maybe not going to do much. I reckon if they have a list or they have like a jacked up QL, probably what I find works, because you can give them generalized pain relief. So if we just do any, like even that little, even not, you might not even get them in a lengthened position. You could just get them literally on their side with their knees bent. If you just do pain relieving grades, like grade 2 plus into the muscle, you could give them just generalized pain relief. And then I would actually strap it. I'd normally, these patients, I would tape them up.
just like a box tape.
Like a box tape, yeah. And then I'd just tell them, look, you got to take it easy for 2 to 3 days. It'll start to settle, and then let's see you in 2 days. And then hopefully it's then maladaptive.
Because I think that's all I achieve with patients in those first few days. It's just like reassurance that sucks and that's normal. So
Yes.
Quick, like.
Yeah. There's a paper by Ivan Lin. He's a researcher here in Perth, and it's beyond drug therapy. And a lot of it is this kind of principles where you're like just reassuring the patient. You can do manual, but the manual is more like widespread effect. We're not like looking to target a particular joint or anything.
Yeah.
I don't know where you guys are at with a presentation like that, but I'd actually discourage anti-inflammatories. What do you think?
My advice varies.
Hey?
My advice varies.
There'd be some recent guidelines that would say they're potentially harmful.
Over how long?
Yeah.
This is the thing. If it's like, I think if they come in severe acute, the anti-inflammatories, I would try like if it's day 1 of the incident, I would try to not give them or suggest anti-inflams.
Really? Okay.
Yep. That based on recent guidelines, they say that look, the body will be in an inflammatory state, which is normal, and so you want to let the body try to start the healing process.
I play devil's advocate there. If they come in, right, and they're acute,
Yeah,
there's an inflammatory response, but if the body is overdoing the inflammatory response,
could be.
sensitizing it,
Yeah,
put the anti-inflammatory at that point, if that drops them by about, say, 40-50%,
yeah.
it's still got a protective mechanism there, but you're probably reducing fear, and you're also getting them doing gentle. Yeah, is that not? I think that's a valid place for them.
I reckon. I think you're right. I think, like, I mean, it's always depends, right? Like, the guidelines can say one thing, but then you can have a patient coming in and they're like clearly inflammatory, like severe night pain, non-red flag. There's no mechanical presentation to it.
Because I usually tell them, try it for 3 days. If it's not working after 3 days, just cut it. It's not going to work.
Yeah.
It's the wrong pathway. But
I would say I generally try to provide. I know it's going to be like if it's a severe tweak, like back sprain, back attack, one of my patients used to call it, I would give it 24 to 72 hours. I just tell them that. That's like when you sprain your ankle, that's when it's most sore. If you can cope without anti-inflammatories, I would try not to take them. But if they're like like you're saying, if they're in like really high pain, they can't function. I think you could potentially get them better quicker with a short dose of anti-inflams.
I feel like I always say some people come in asking if they should take it for the like anti-inflammatory effect, in which maybe they're only taking it for that effect, don't. But like that sore that you can't do anything.
Yeah.
Like taking it on a day when it's really sore.
When we did our masters, they were really pro Panadol. They just said you should take like as much Panadol as you can, so you just don't feel it, and then you can kind of like see what the body's doing mechanically.
I'm not sure, but this is where the guesswork comes in, because like, when you're looking at medication, you're guessing what pathway you're trying. So like, COX-2 inhibitors, but which ones you take? Yeah,
that's true.
And then you've got COX-1 inhibitor, which is your Panadol, which might do jack shit for anybody.
You're right, yeah.
First, I feel like with nerve pain, it was brilliant. It was like, 5 days of that was great.
Yeah.
Of course, but my sort of attitude is, it's given that, I just think the medication gives people a window of opportunity to move.
It can do, yeah. Well, the other thing is if they go to a doctor, I don't know what it's like there, but the doctors here will give them muscle relaxant.
Yeah.
Like that's what they do here, but the guidelines don't say that. So I think a lot of it is, you're right, like it just depends on how they present. But this paper by Ivan Lin is basically there are educational and probably some positional and like this control stuff, but also manual therapy things we can try. And then I think it just comes back to the individual. Like you just have to test them and see. Yeah. But I've had some patients, like my mum, for example, although granted hers was sciatica, she had the anti-inflammatories and it was like night to day different, like 30% better. Yeah.
If you've got a sensitized nerve that's sensitized to inflammatory chemicals, so like stretch sensitive or compressive sensitive, that's the nicest thing you can do, because it's the easiest thing that's going to work. It's like, bang, you're off.
It was like, and I mean also, so this is another part of the conversation. Like, I don't know what the doctors are like there, but they love Lyrica here. They just bust it out willy nilly.
There's a bit of that going on at the moment, I think.
And so, like, but and if you look at the actual trials, it's no better than placebo for back pain. But when my mum had it, it was like night to day different. Like for her, it was like significantly better.
Yeah.
And then she weaned off it. So, yeah, I think all these things are options. Yeah.
I think you've got to look at the context. The reason the person's presenting to you, like if they're in acute pain, is they want out of acute. You kind of got to look at what options do they have available to them at that time.
Yeah.
Something's going to stick.
Yeah. Yeah. Any other questions about that ipsilateral? And then I'll show you some cases.
When you've settled them down.
Yeah.
Right. We've got them at their happy place.
Yes.
Are you doing, what functional assessments are you then doing to what you have to go and tidy up next? Like this, is it a strengthening component, or is it like just a tightness component? Like are you just doing a lot of sort of loaded single leg stuff?
Yeah.
Sort of like really sort of hunting into that sort of lateral flexion pattern.
Pretty much. Like, and the other thing that I'm looking for in second opinion, I want to know, right, that they have full ROM.
Yeah.
Full flexion, full side flexion, and then full combined. So a lot of the times when I'm doing a second opinion, I'll look at their ROM and they actually still have a combined movement impairment. So like I'll take them, into like combine. So in prone, I'll take them into combine. I'll show you what I mean. Have we got? Can you flip the camera to the bed? We'll do it on Dave.
Back to all time tonight.
So flip onto your tummy, mate. So can you get into like his L4-5 transverse process on the left there, Tim?
I will when I have more hands to hold this camera, sorry.
Just got to palm it off to someone else.
Yeah.
So tell us if it brings on your symptoms there, Dave, when he pushes.
No.
A little bit. A little bit. Thighs.
Okay. Yeah. So then do a full Mackenzie extension. Do the same pressure. And then shift your hips over to the right there, Dave. And then do the same pressure.
I don't need to push.
No, I don't need to push. Yeah.
What, sore?
Yeah, so as soon as I do that, something there. Yeah.
Yeah,
I can feel it now.
Yeah. So like this is the sort of stuff I'd be looking at in second opinion. I'd be thinking, have we made sure that the patient actually has restored full mobility? And a lot of times you're quite right. Like you basically end up giving them like single leg strength, single leg loaded strength with their trunk forward. But I wouldn't want to get them into too much heavy strength if I haven't proven that their ROM is full. Yeah. That would be.
And they're probably, sorry.
That's good.
You're typically fine with them though. But they're probably strong on two legs. But as soon as you put them out,
yes. You've exactly right. So like that's why if you check them with you bang on. Like basically, if you're checking all these like two-legged deadlifts, two-legged sit to stand, two-legged weighted sit to stand, you won't pick up anything. But then when you isolate the level or the side, and then that you just kind of, I would play around with the compensated Trendelenburg and then Trendelenburg idea.
Yeah, because I tend to often I like getting marked like a march and then farmers carry and load it, and that's where because you tend to find you pick them up there pretty quick, I reckon.
Yeah, I think that's legit. Yeah. So yeah, it's like in my head, I'm thinking if they come in with that ipsilateral side, this is where my head would go for assessment, and then I've kind of got like a spectrum of am I going to deload them into non-weight bearing, or am I going to just straight away try and give them therapeutic exercise in weight bearing? Yeah. Does that make sense?
Yeah.
The thing is, this is all great in theory, but then you get patients where they're actually a different motor control in different positions. So some patients are more a passive extender in standing, they're an active extender in sitting, and they're an ipsilateral like with walking. And their pain can be in various locations. So I think all of that is then a clinical reasoning issue. So you don't want to give them too many cues that first session. I would prioritize what gives you best bang for your buck. Yeah. So that's you do. So I am that. I get with my back. I get your left side where you get it. That's where I get it's the same for me. But then if I stand too much, I'm a passive extender and my back gets sore and I have to lean forward, and I'm sitting. I've been sitting all day. I have to sit with actually an anterior tilt. But when I deadlift, I have to relax my back. So I'm what they call a multi-directional. So you'll get some motor control presentations where the cues have to be different depending on their symptomology. Yeah. Does that make sense?
Yeah, I suppose that's one of these ones like those. You get people to a certain point, you've got to go looking again.
You do.
Because it was like, yeah, you were passing extended, but there's more of this. There's more layers there.
The other thing is it can actually change. So they can, at the start of rehab, they can be one presentation, and then as they get better, they can kind of like go through a bit of a shapeshift through the process. So I think it really depends on how they are on that session. But you will have some patients where they start off, an active extender, and they're an active extender all the way through. Typically, if it's like chronic, persistent low back, they'll have that ingrained pattern, and then you have to undo that. But then you get some patients where it's more like your back, where like last week you were different to how you are now. Yeah, makes it interesting. Yeah. All right, shall I show some cases? So here's a patient of mine, real patient, who okay, should be able to see that. Patient's name's Susan. So this patient came in like that. So she had the pain on the right side, that like lower QL, little bit of posterior buttock SRJ region. And she came in with a list, shifted off to the left. Okay. It was constant. It had been quite high levels of pain. Right. She worked actually at Curtin Uni as a marketing officer. So it's sedentary job. Her pain was actually worse with sitting, bending, coughing and sneezing, and she'd stop lifting because whenever she'd lift, it would hurt her back. Okay. It was better when she was on her elbows and standing walking. So the kind of like classic Mackenzie type. Right. She had severe night pain when she'd roll over, and she had stiffness in the morning in her back for like half an hour. This all started about 15 years prior, when she lifted something and then it tweaked her back and then it eased after like 6 weeks. 2 years, so when she was 32, so 2 years prior to seeing me, she was ice skating. She felt like she was wobbling and she kind of braced to protect her back, fell forward, and then she started noticing severe back pain with pain into her legs. She saw a physio who did hands-on at the start, and then she'd seen the physio for 2 years, basically every fortnight, where he'd done like hands-on, getting her to breathe, like just breathe through the movements, and gave her some pre-functional strengthening, so clams, 4-point hip extension, that kind of thing. He said to her, "You've got poor core stability." Right? So he'd been seeing her like every couple of weeks, and I said, what was he doing like recently? And she goes, "Oh, it was more like talking and exercise." This recent pain that had caused her to be like that was 3 days ago, before me seeing her. She was really stressed at work, where she'd been sitting for like 2 to 3 hours straight. Okay. She went home. She was a bit of a perfectionist type person. She went home and cleaned her bathroom for an hour. Okay. She's like, I don't know, what are they called? OCD. She's OCD. And then she bent forward and she felt her back go. Medical history-wise, she was pretty good. She was pretty active, pretty fit. She was running 4 to 8 kilometers a couple of times a week. She had a Pilates program she was kind of doing at home herself as well. She hadn't had any scans. Currently, she was really scared to bend. She didn't want to bend. She wanted to be able to bend. She wanted to be confident to clean her house. She wasn't sure whether she needed a scan. Okay. She was like she wanted that as an outcome from seeing me. She actually wanted to just get rid of the pain to prevent it. Because she wanted to fall pregnant after her wedding, which was the following year. I'd seen her sister before, which had helped. Okay. When I looked at her, so if we're getting into the physical exam now, she had a massive left list. She was guarded the whole time. Whenever I'd get her to bend forward, she'd like brace. When she was sitting there, it was like tense, like she was like holding her back like this. When she was standing, it was the same. When I got her to try to come forward to lift up something, I got like a little weight, like dumbbell putting up like this. She'd go to bend forward, she'd brace her back. I said, just relax your back. She'd still brace, but she could hardly bend. It was like she was like kind of only going to like quarter range, like just to the top of her thighs. Her extension helped. So going into extension she felt was good. When she'd go off to so that's right lateral flexion, that's left lateral flexion. When she went off to the right, it made it worse. When she went off to the left, it eased. When I combined flexion with right lateral flexion, it was really sore. When we extended and went off to the left, it helped. Pushing on L4-5 was sore centrally, but she was really sore on L4-5-5S1 on the right. And she was tender on the QL on that right side. Okay? Her hip range of motion was a little bit tight, but overall good. Her neuro was completely normal. And I did a short form Orobro with her, and that was 60. So what I want you guys to do, just for a couple of minutes, is I want you to think about her, because these are the kind of cases I'll see for second opinion, right? Is there anything else subjectively you'd want to know? So maybe if you can split up into twos, anything else subjectively you'd want to know about her case? And anything else physical you'd want to test? Anything. And then last thing, I want you to think about if she's, the whole thing they love at universities now and in the research world is biopsychosocial. If you think of her like a piece of a pie, biopsychosocial, what percentage of her case do you think is biological? What percentage of her case, so if it's 100%, how much is bio, how much is psychological, how much is social? I'll give you like 4 or 5 minutes to just think through that. So go through subjective things that you think I might have missed, physical things that you'd want to check for her, and then biopsychosocial. Hey? What? Do you want me to put... Hang on. Hang on. One sec. What was that?
Can you pull the objective back up?
Yeah, I'll pull it up, yeah. Okay, here. I'll scroll through the slides quickly, slowly. So this is... That's what her pain diagram looked like. My kids, I can't hear a thing, eh? That's the back. That's how she looked. These are the pain scores. These are her AGs. This is easing. That's her history. This is the recent history. So she's just post 72 hours injury. She's a good patient, this one. She's listened to everything we said. She's very compliant. These are her beliefs. This is her standing, what she looked like just standing there and sitting. So when I got her relaxed, she still had really limited ROM. Like she just had no ROM. Yeah. Combined ROM would really piss it off. That was her palpation. This is hip. Is that too hard or is that workable? So have a think of what subjective stuff you might want to ask, and then definitely physical stuff, a lot of what we've gone through in the past few sessions.
Forward and right, but she was happy going to the left.
Was it flexion, right side flexion?
It's flexion, right side flexion. Yep.
Yeah.
How did you respond to physio? Like her previous physio? Did she get any benefit? Was there anything that she felt that was helpful?
You know, it's funny, Dave, like a lot of these patients, they don't know any different. So they'll just keep going. And she was kind of that nature, like she was kind of non-offensive. Like she didn't want to upset the apple cart.
Did you ask her much about like her sitting position at work?
Yeah. Yeah.
But she was sitting, did she sit more on her sort of her right hip, right glute, or left, or what were their setup?
Yeah. She at the moment she was like jacked up. Like she was all on the left because she was kind of like veering off away from it. But prior to that, she was actually slumping, if anything.
Was her workstation set up predominantly like to the right or to the left or directly in front? Was there any indications like that?
That's a good question. I can't actually remember, but the thing was she sat a lot. Like she was sitting like 8-9 hours a day. That's the one thing I remember.
And she's gone from being pretty active to just deconditioned.
Yes. Yeah. And she's like to me, you know, I say that about the biopsychosocial because I think sometimes the academics like hyper focus on the psych, right? But I actually think she had things that she was thinking about her back that if we didn't deal with it, it was probably going to potentially derail her.
That's been in the objective. Like we did lifting, but we didn't do sitting or standing or single leg. You could do those things.
Yeah. But she was really shifted, eh?
She was big shifted.
Yeah, so maybe you're not getting your single leg on that first day, but you know, look at sitting.
Did she correct the shift?
Very good question. Yes, we could.
Because she's got elements that seem a bit Mackenzie. She's better approach, she's better standing, she's better in extended position. You could sort of go, or you probably, I would have thought people sort of rattling down that kind of disky kind of presentation.
Yeah.
Whether that's a maladaptive response.
So I think she's like, this is what I'm trying to put to you guys. Like, if they come in like day one, you're thinking, okay, well maybe I'd always try and test and see if you can change the list. But if you can't change it, you just assume it's adaptive, helpful, and you just leave it. And you just strap it up and tell them it's going to get better. Book them in 2 days. But if they come in like 3 days post and you can correct it and it's better, then that's when I would be using this Mackenzie stuff for sure. But a little plot twist. When I did correct her, list, she still couldn't bend all the way.
You still couldn't bend all the way?
No. She could only bend like halfway. Like it did actually help her when I corrected her list, but she was like stuck. Like she couldn't bend.
After you corrected the list, did you try things like repeated extensions with her to see if that influenced it?
She was like, it's like it wouldn't go. Like it wasn't really responding to repeated.
And it was unilateral on the right, L5S1, L5-4?
L5S1 right primarily, yeah.
I'm just picking up Ari to go.
Snag flexion?
You're picking up what I'm throwing down. So with her, when I snagged her into flexion, her ROM was significantly better. Corrected her list, snagged her into flexion, 90% better.
So she has got that sort of compressive, that stretch compressive pattern, right side of that.
Yeah. So I would classify her. I would actually say, I said it at the start of the session today. I would say she's a movement impairment. She's both actually. She's a mix of control and movement. But this is where it's like not as easy as the textbook because they'll come in with like a blend of presentations. So when she was corrected, better, but not fixed. When we snagged her in a corrected list, even better. Repeated didn't really work. So what home exercise program are you going to give for this patient?
Get snags for a start.
Yeah.
Give herself snags. Yeah. Yep. What else?
Well, if you can correct the list, she could cycle out against the wall, correct the list, then snag flexion after.
Yep.
And if she's compressing on that right side, you want to lengthen that right side probably. Especially if she's got left side flexion better. That's a happy place.
Yep.
I'm going to try and detone that.
Yep.
That's probably where I would start with it. It's just that simple stuff.
And treatment planning wise, she comes in. What's your short-term treatment plan?
On that pattern there, if the list is corrected,
Yep.
I mean, I'd probably start her off with some sort of left-sided lateral flexion or left rotation kind of mold to begin with.
Yeah. Like out of that aggravating.
Yeah, to bring it out aggravating and bring it into the just slowly progressive forward that. Same with exercise.
Yeah.
That's what I would think.
How many times would you see her, you guys, you reckon?
Until
over what time frame?
Yeah, until she's ready for gym or until she's discharged.
If she came in and all that stuff we just said helped, what would be your forecast for the next 6 weeks?
I think with her, she would be somebody I'd want to see fairly quickly after that initial treatment because I'd want to, she's tracking in the right direction. Like she's maintaining it because if she's got that biopsychosocial, she's got fear avoidance,
she was quite anxious actually. She was actually quite anxious. That was my impression.
If I saw her on the Monday, I would try and get to see her Thursday, Friday, and then get one early the week after.
Yeah.
One the work, then after that, then start plot it out from there.
We have me and Dave have been speaking about we might do the manual therapy course hosted at your clinic, right? We have a bit of we'll see. You get basically free tickets, so but if we have a thing where if you don't know what to do, like if you're looking at the case and it's a bit overwhelming, we homogeneously suggest twice a week for 2 weeks. You just do like a little block and see if the manual's working. The other school of thought, it's a bit more old school, but you could literally see them twice a week until they've got full ROM. Because that's probably when the manual's going to help her.
And she's in that acute to subacute phase,
yeah. Yeah. That's what I generally recommend even now. Like, but then you want to wean them off. Like you don't want them passive dependent. What do you think of her biopsychosocial mix?
I think it's more. So she might be one of these ones to me that it's like a Stuart McGill one. I remember chatting to him. He says sometimes if you can start clearing that stuff up, a lot of it will start to resolve anyway. But I wonder with her, like if she's sitting, she's in that flexion, and I'd be wondering if she's actually sitting flex, right side flexion. And if you can bring her out of that, and that's more comfortable, then that might make things an awful lot better. Get her moving during the day. And see that psychosocial sort of component sits after that.
With her, yeah, you could definitely go like directional preference. You know, you could sort of see if she's better like in that coronal plane, like changing it up. The other thing is just like you said, the volume of sitting, so that was a key thing I got with her. And a lot of these private enterprises, they'll get workstation setup assessments and they can get sit-stand desks. It doesn't cost much, you know. So we did that. We actually ended up doing that with her. What about her beliefs around her back?
Yeah, interested in knowing what she thought was causing her pain.
Do you think a scan's going to help or harm?
I wouldn't touch it.
Yeah, probably harm.
Yeah. So, what do you reckon happened with her?
You got a scan from a GP?
No, she probably. I saw her. I reckon about 30 times over the next 18 months to 2 years. But we ended up doing because her physio had given her like more Pilates-esque. And I felt like she needed more like confidence to bend. So I ended up giving her like ultimately like relaxed deadlifts, Jefferson curls, quite heavy, single leg. Probably another 5 or 6 times she asked should she get a scan, and I blocked her. You shall not pass. No scan. So she didn't get a scan. In my opinion, it probably would have been harmful.
Would have your thought process changed if she was the same stuff but extension aggravated?
Beg your pardon?
Would your thought process changed if she was more extension aggravated?
No. I think her thoughts around her back were just kind of, she had a lot of low self-efficacy around her control of her back. I think by the end of it, she sort of realized she could trust it. I think she'd been fear avoidant of bending for at least 2 years, like from the ice skating incident.
See, from a treatment perspective, then, with those persistent complex ones.
Yeah.
Once you've given them more, how would I say, if their confidence improves that their back is not a problem, or there's something that's going on, they've got self-efficacy. That's time to start cutting them a little further with some physio as well, sort of spacing it.
Yeah. It was like there was like a blocker treatment at the start, and then we ended up doing gym sessions, and she it all kind of panned out. Like she ended up falling, getting married, falling pregnant. It was like a Cinderella story, but
I don't remember that from Cinderella.
well, Cinderella didn't have a good physio. What do you reckon her biopsychosocial mix was when she came in?
Pretty high psych.
High psych. Yeah. So she's pretty, like, as a patient, I don't know if you guys bust out that short form Orobro, but that was my master's thesis was in that. And if they've got over 50, you've got to at least spend some of the first session educating them.
I was going to ask you why you picked the short form Orobro over something like a TAM.
The reason I like the short form is it's quick, takes like 2 minutes. It's validated. In our study we showed it's valid and reliable compared to the long form. And you can use it not just for fear avoidance, it like covers multiple domains.
A good starting one.
Beg your pardon?
Makes it a good starting one.
I think it's a good starting one. It's like a quick screen. But because she scored 60 out of 100, that makes you have to at least spend some time de-threatening. And if you're being really picky, you can actually go into each individual question. And you can, like, for example, question 9 is fear avoidance. Because it'll say, like, feeling pain is a suggestion that I should avoid moving.
That's not what I'm doing. Yeah.
So you can ask them, you can go, well, like, so I think the good physios won't just like take the gross result, but they'll look at each domain and they'll go, well, why did you think you're not going to get better in 3 months? Like the self-reported prognosis, like what makes you think that? And obviously with someone like her, she'll just go, well, look, it's been there for so long. And so it just opens up that, because like it opens up the conversation that yes, she'll have a short-term treatment planning element, but what she really wanted was prevention. So yeah, I think and she was a bit anxious and depressed and stressed about it. So I think there's some cases where it's just a clear-cut mechanical presentation, and then there's people like her where it's like a mixture. And I think it's worth delving into the psych with her. Is there anything else you'd consider doing with her?
Outside of your like CBT movement-based stuff you did with her, did she receive any other psych intervention?
No. That's the other thing is I worry this is where it can, like, the pendulum can swing the other way. Is that we're overdoing the psych, because there's a recent study this just this week that physios with these kind of patients, it is within our scope to just ask around, at least superficially, their thoughts around their injury. I try not to pull the trigger on referral unless I'm really concerned that this person's going to become a complex chronic case, or they really need psych input. And the type of psychologist you refer, I don't know if you guys have got them there, but it's like a pain psychologist. It's quite specialized. And you're then looking more multidisciplinary team, pain specialist, which can, I think, sometimes blow it up a bit. Like it can. So yeah, I've had some, like, if the patient's definitely, if they're like suicidal, then I'm thinking for sure on referral. But if they're more just like frustrated, questions about this, whether they need a scan, questions about whether it's ever going to get better, questions about fear avoidance, those sorts of things I'm happy to tackle.
Yeah, that sort of patient, I would give a DAS 21 and expect a stress subscale to be high.
Yeah, yeah.
If that wasn't improving as I started treating her back, I would refer her on or give her other tools.
Yeah, yeah, that's fair. I think the fact that you're even the good physios, as long as you, especially if it's compo. I mean, she wasn't, but even the private cases, I'll do some of this psychological screening. Do you guys do that? Like, you'll still give them the questionnaires?
Yeah.
You can just ask them the questions as well. You know, you don't have to necessarily give them the questionnaires. You can just ask them, just go like, do you feel like you need to talk to someone about this? Like, do you think you want some more strategies other than what we're doing? Yeah. Yeah, but it took a while. So we kind of like, she stopped going to the other one. The main role with specialist physio is to kind of get them to go back to their previous physio. But in her case, yeah, we just did more of that cognitive functional therapy approach, graded exposure, and got her doing ultimately heavy weights. At the start, there's some other stuff you could have tried. You know, we could have done, you know, more just Maitland treatment, and you could see how that goes. You could have tried some of this like ipsilateral control stuff and see if it was a QL that was jamming everything up. But I think the low hanging fruit is to try to correct the list. If that works, then great. If it doesn't, then you've got snags. If that doesn't work, you can try some Maitland. If that doesn't work, you can try some of this other just like hands-off approach. But yeah, she was an acute on chronic biopsychosocial.
Across those sessions, when she had a flare-up,
Yeah.
what was your education like around that flare-up, particularly if it was in relation to something you'd challenged her with?
Yeah. That's a good point because like I like to I don't know if you guys are in the habit of doing this, but I draw out that graph, right? Like X, Y axis, and I'll say all the patients want this, and I'll draw a line down. And I'll say that's not going to happen. It's pretty much going to be like a Lord of the Rings style journey. And they most of the patients, if they've long-term pain, they're pretty happy with that.
Mm.
So I set the scene in the first session. She would, yeah, she'd revert back to like a lot of stress if she did get a flare. I think that might have been what happened. Like that's probably why it was 30 sessions because like she'd go good. If someone has a regression, I'm pretty happy to do a little block of a couple of weeks of manual. And then I'll just space it out again. But it's always reassurance, de-threatening. I was very happy that we ended up never having to refer for imaging. I think the imaging would have just complicated it. Yeah. Good case. Pretty. I think she was a good biopsychosocial mix. Yeah. Have you guys got any other challenging back ones at the moment?
Yeah. Yeah, Jim. I've got a patient that scores high on question 9 on that, a rebro. He's been coming to the clinic for maybe 18 months under work cover.
Ooh.
And part of the reason it's been prolonged is at home he fell off a ladder and had a head injury and is now getting rehab for like a traumatic brain injury on top of his back.
Bloody hell.
And he took probably 6 months to get him to like arm swing while walking, like you walk like the Tin Man.
Is he an active extender?
Yeah, and just like an active everythinker who's just bracing at all times.
Yeah.
Breathing cues worked with him, like change it a bit.
Have you done the body scanning with him?
Yeah, I've done body scanning and some other sort of mindfulness things as well. And he, prior to the injury, we'd just built into like the initials of some gym, like some basic things where his back was supported, more like arm and leg things.
Yeah.
Just starting to do like some unsupported back stuff, but we're now back at a phase where I haven't seen him for 5 months. So I think I'm gonna have to start some of those other things again.
Is he multidisciplinary?
Yes, yeah, it is now post TBI. Wasn't significantly before.
And how's his like has work cover? They basically give him a homogeneous scan. So what does his scan show?
Good question. Off the top of my head, nothing.
Nothing
Yeah,
sinister. No.
nothing sinister.
So he'd be, yeah. I mean, a lot of this control stuff we've gone through, he'd be. It's like it's always this like trying to work between their thoughts and how they move, and he sounds like he sounds textbook active extender.
And
Yeah.
one of the challenges I have with implementing something in with him is like his pain can be latent after the challenging activity. So like
Oh
I'm
yeah.
trying to do some of that new motor control stuff. You might test 3 or 4 things and he goes, "Oh, it's sore now. I don't know which of those it was that was too much." And yeah, so I've just sort of layered one thing in at a time, which is part of the reason he's taken as long as he has.
And he doesn't have leg pain.
No, just that.
Oh, these work cover ones, man, they're absolutely brutal. Yeah, they're
I think he's primarily like a facet arthropathy is the biological thing. But
oh yeah. Has he had injections or?
he had injections, yes, with minimal effect.
Yeah. And what's his job? What does he need to get back to? Or what are they? What was
He
he?
was a groundskeeper, so quite manual. And he got to a period of time where he realized if he did more manual work, it didn't like his back was sore, but his back was always sore, so he just sort of built back into it.
Oh yeah.
Um,
He could be a good one. We did one. I think we did one with Jez. But it could be good to do a specialist. Because we do some work cover, some Queensland work cover second opinions, and they do unless I don't know because sometimes there's something that's out of the box that we could try, but some of these work cover ones just don't get better, eh? Like they basically just never get better.
yeah, there was something like that, definitely.
Yeah, which is pretty depressing to be honest. But
Seemed improving from where he's are, but whether if he's ever truly 100% better, yeah.
yeah, I've had like my mentor used to say that like we'd had some and like we threw the absolute kitchen sink at them and literally nothing worked. And like we got everyone involved, epidurals and bloody pain. I've had some patients on like the spinal cord stimulators and stuff. Have you seen them? Um, and it just like doesn't work. Yeah, it's hard. All right.
Yeah, excited to see how he is when he comes back.
Yeah, those work cover ones. What's your guys' percentage of work cover?
I think it was pretty last year. It's only about 10%, 10-15% of that.
So it's not like a huge part.
I mean, like 10-15% of that, less than 20% work at DVA, rest private.
I prefer the private patients though.
Well, I think they come because they want to get better.
They want to get better.
That's the big massive difference between working out in the public system is they come here because they want to get better, not because
Yeah. The compos, God bless them, but it's just, I don't know. They have much higher psych.
Yeah. And some of the things are like unnecessarily protracted as well, like just how long it takes to get a scan if they need a scan and
Oh man, yeah.
Going to see a specialist, it might be by the time you've seen him for the 12th session versus that private patient, you
Oh
could be.
yeah. Well, I had one. You know, like the blue black flags where they have like the employer angst and stuff.
Yeah.
I had a patient who was like hating on her employer, like would never go back. The employer was an absolute jerk. She was 2 months in. She'd been resting in bed. She'd had no physio.
Oh,
And she was like a proper movement impairment. She came in. I said, I did a video assessment with her. She's in Perth. I did a video assessment with her. I was like, you need to just come into the clinic. I literally just did some mobs and sideline, the most basic mobs. And she gets up, she's like 50% better. And she'd been resting in bed for 2 months. So there's like, the paper trails of compo do my head in. Each of the case managers has like 50 or 60 patients,
yeah, right.
which is why they are always so slow at approving stuff. Yeah, it's like it's a pretty, I don't know. I don't, I'm the system's kind of screwed. Yeah.
There's a system.
Yeah.
That's the thing. As people forget, there's other countries that don't have a system like that.
Some of this, well, that's exactly, yeah, that's fair. That's true. A lot of them don't even have that, you know.
I think that's the thing you tend to forget is like you got to look at this system that we work with here compared to other places.
Yeah, there's like, I mean, yeah, if there's no system or they just can't do anything, you know, like they just can't work anymore.
You just treat like everybody else.
It should be like a private case, but I think you're right, Tim. It's just like all these blockages that stop them getting good early care.
It just takes too long. Yeah.
Yeah, that's probably what because I don't really like to see them in my role till like unless we have to, and it's like a lot of it should get better if they're getting early care by 6 weeks.
Okay.
Yeah.
Oh, yeah. I did have a good flexion based back one that used your motor control stuff. It came out really good.
Did it work?
It was really good actually. It was 5 years post surgery, and just really poor belief system, aberrant movement, and then just used all that stuff, and he's I know getting back to what he wants to do.
Is he stoked?
Yeah, well, he ended up like going back to sport, which he didn't think he was going to do.
Really?
Yeah, what's the first thing if we do it? And I went, fucking, we'll settle it down.
It's so good, mate.
It was
Yeah,
good.
like,
He was really good. It was a bit of a shame I never videoed him doing some of his test stuff.
oh, that would have been cool. Yeah, that would have been cool.
He was the perfect technician, and everything he did just overbraced everything.
Yeah. Once you see this stuff, you'll never unsee it. It's like it's just sometimes it's subtle, and like I said, they can shift, like they can shape shift. So it's hard, but yeah, I think it's very good. They're very good strategies to be aware of. Yeah.
He was. Thank you for that.
No worries, mate.
I was going to say that conversation we're having on the email. I've
Yeah.
also accommodation nearby too, if
Is there?
required. Yeah, so basically, it's a good little area if you want to have a think about it.
Do you reckon you could get like, because when we come to Brisbane, a lot of physios come out, like 20 or 30.
Yeah, look, I think it would be a squeeze down here at Arana, but 10 minutes away is the other clinic. We get 30 in there easily because you get 3 in a room, 4 rooms. So there's 12 already. You've got the gym space is 150 square.
So it's pretty big there.
The beds in there. If it's a nice day, you can put a couple of people outside. But the other thing is amenities for eating, coffee. There's a pub next door opening.
Well, that's good.
So there's actually
so-
the other, like physios in Brisbane, like North Side, there's a lot of physio clinics in Brisbane. And there's a little place, there's a sort of a conference hotel about 12 minutes away called the Edens Hill. I can send you a link to that.
Yeah.
That's a simple for a taxi to pack you into.
We normally have like it's a pretty popular course, so we normally have like 20 to 30, I would say.
I've got in touch with Asta, and they can supply beds, extra beds as well.
Okay.
So if you're interested, put it past James and stuff like that. But
Yeah.
they'd like to have you.
Yeah, it's good. It's like we love it because it's like it's stuff you use you'll use it forever. Yeah. And like It's pretty good for the clinics that host it because it's like,
Just have a think. If you want to sort of host it there, we'd be delighted to host you.
okay, I'll message James. Yeah, it sounds good. Sounds great.
I'll chat to my mate because his wife is she's part of the management team at that hotel area.
Okay,
Your mate's rates for that.
awesome.
Right. Yeah.
So good, guys. All right,
All right. See you next time, man.
great to see you guys.
Yeah, later.
Bye bye.
All right.